Good evening, everyone who's joined. Welcome. My name is Asma. I am so excited to be hosting this event for you this evening because it's so important. I know that this is a topic which I personally haven't sort of known a lot about, and this is why we do these kind of talks. This event is called You're Not Imagining It. We're talking about long COVID, ME, and other invisible illnesses in South Asian communities specifically. So you might have joined because you yourself are experiencing some symptoms. You might be supporting someone who you know is perhaps going through it, or maybe you just want to know a little bit more about the condition because there are so many people that are actually living with long COVID these days, and the symptoms can be extremely debilitating. You could be struggling to get some answers. And if you're in a South Asian community, then these challenges are so much greater. There's lower rates of diagnosis, representation, and research, all things that we're going to touch on this evening. So we want to raise awareness with you tonight. We want to share with you information from our experts. And we do have two brilliant experts joining us this evening. I've got Dr. Binita Kane, who is one of the UK's leading long COVID specialists. She's got over 25 years experience in the NHS. And also with us tonight, we've got Dr. Sanjay Gupta, another leading specialist in COVID and also in POTS, autonomic dysfunction, and cardiovascular effects of long COVID as well. Sanjay, Benita, thank you so much for joining this evening. I thought we could maybe start with how you two know each other because it's quite an interesting story.
Good evening, everyone. It's really great that you've joined us. Yeah, Sanjay and I, we go back a long way. So we were junior doctors together. I'm not going to tell you quite how long it was, but it was over 20 years ago. And we worked together at Wythenshawe Hospital, didn't we, Sanjay?
It was 2001, I think,
Oh,
2001 or
he's
You've
giving it
given it
away.
away. Yes. And then we reconnected because I think both of us have really stepped outside of traditional medicine to develop specialism in this role, in this condition, and treat patients. There's not many of us actually working in this space. So we've kind of all seek each other out and support each other as well.
And, when we talk about the fact there's not many of you in this space, but long COVID has affected millions of people. So maybe we start with that, Benita. Like, why is it so important that we're having this conversation? And maybe why is it so important we're having it, now in South Asian Heritage Month?
Yeah, I mean, the health inequalities affecting patients from South Asian backgrounds isn't new. We've known about it for many decades, but I think the COVID pandemic really laid it bare. So we know that people from a Black and South Asian background were disproportionately affected by COVID, but yet when the post-COVID services were set up, there was an underrepresentation of referrals for people of South Asian and Black origin. And Nisreen Alwan, who's an amazing professor, she's written about this. And she says that, she describes it as medical ambivalence. So her research, which was qualitative, they interviewed lots of patients, found that people from ethnic minority communities with long COVID often felt their symptoms were doubted, inconsistently managed, or not taken seriously. Participants describe stigma, uncertainty, and difficulty navigating healthcare services. And so that's adding to the burden of actually living with a condition which is already poorly understood. And I definitely see an underrepresentation of South Asians and people from Black populations also in my patient group. I don't know about you, Sanjay.
Yeah, absolutely. I agree with you. I mean, I think this conversation matters because long COVID didn't create a new problem. I think it exposed one that had always been there. For decades, we've struggled to understand illnesses that don't fit neatly into our medical boxes. And COVID simply produced millions of people with the same symptoms at the same time, making it impossible to ignore. And unfortunately, those who have historically been least likely to be believed, women and people from ethnic minority communities, often found themselves facing yet another invisible barrier. So, not just the illness itself, but the feeling of having to convince somebody that they were ill. And that is an enormous burden. So, tonight, I think, is not really about long COVID alone. It's about listening better, and it's about recognizing suffering even when our investigations haven't yet caught up with it.
That's a really good point. And just in light of talking about listening, for everyone that has joined, we will be opening the floor for questions at the end of this conversation. So do have them ready if you want to add them into the chat later. We will get round to them. But just on that, Sanjay, saying that these invisible illnesses, it is something that was prevalent before long COVID kind of came along. And is that specifically when you both talk about that with healthcare professionals, as in like that struggle?
Yeah, I think the word invisible is a bit unfair because the suffering is very visible. You just have to look. The number of hospital attendances, the number of A&E attendances, uh, people being off work for a prolonged period of time, people coming into your office and crying. The suffering is real. The suffering is visible. We have to acknowledge as a medical profession that we've just chosen to be blind to the things that don't fit in our kind of traditional education, the things that we haven't been educated about, we've gotten to the point where, oh, well, those things don't matter. And the reality is, I always say to my patients, don't go to a doctor who says, I understand long COVID. Go to a doctor who says, I don't understand it, but I see your suffering and I am still willing to help. And so that is so important that we say it's an invisible illness. It isn't. We need to open our eyes. We need to become aware that even though there may not be a label or there may not be a blood test that is abnormal, people's suffering is real.
Binita, if someone watching or with us this evening has never really heard of long COVID before tonight, what would you want them to understand first so that they are armed to go and know to go to their doctor?
Yeah, I mean, I think we probably need to take a step back because people are sometimes suffering with symptoms that they just don't understand. They might feel more fatigued than usual. They might be not thinking as clearly. They might feel breathless. They might get palpitations. They might have all these sort of symptoms, and they'll go and see a doctor and be told, actually, oh, I've done your blood test. If they've even been seen physically, which often they're not, and everything's normal, and off you go. And that can be very soul destroying because you've plucked up the courage to go and you've had an assessment. So I think taking a step back before we get to the diagnosis of long COVID, it's useful to understand, well, what is it? So this was a patient coined term. This was coined by the patient population in 2020 when they realized they were not getting better from a COVID infection. Now, it is unfortunately 6 years later, we still don't have a diagnostic test. And so it is still what we call a clinical diagnosis, where you are making the diagnosis based on symptoms and excluding other things. And it's really important to know that the symptoms of long COVID can overlap with many, many, many other things, with thyroid disease, with diabetes, with perimenopause, with B12 deficiency, iron deficiency. All of these things can produce a similar set of symptoms. And therefore, it's very, very important that when you go and see a doctor about your symptoms, they take a very detailed history. They take the story, they listen to you, and they try and work out what's going on. And they exclude all of those things first. Now, the sort of definition that the World Health Organization and NICE, which is our UK body, have come up with is that it becomes long COVID if you've had persistent symptoms for 3 months after a COVID infection. And that doesn't have to be linear. You can get a bit better and then get worse or develop new symptoms. But it's that 3 month point where you've excluded everything else. And there are often sort of common and typical symptoms and features which we'll get onto. So that's a kind of a wordy answer to your question. Sanjay, have you got anything to add to that?
Yeah, I've always sort of thought that long COVID isn't one disease. It's just an umbrella term describing people who've never really returned to their previous level of health after COVID infection. And that's what makes it quite difficult because it's different people develop different problems. Some people have lung problems, some people develop heart problems, immune dysfunction, and some people develop autonomic nervous system dysfunction, which is the particularly difficult constellation of symptoms for patients to describe and for doctors to identify, because in those there's no one single test that picks up autonomic dysfunction, and therefore we've become so organ centered. You go to a cardiologist who's only interested in your heart, and you go to a lung specialist and they're only interested in your lungs, and they somehow seem to think that if it's not a lung problem, it's not their problem, although it's still the patient's problem. So I think the term long COVID doesn't, it's not one disease. And you're quite right that they need to go and they need to be evaluated, have a very broad spectrum, look for everything. And then there is a particular group of patients under this umbrella, where you test everything, you correct everything, but the patient continues to suffer and they say, I'm not feeling any better. And that is the particular part of long COVID, which is really interesting and can be very satisfying to treat, provided it is recognized.
And I'd agree with that, Sanjay, because long COVID itself is a massive umbrella term, isn't it? And and I sort of divide it into these two big groups. So there was a group of patients who got very, very sick with COVID or hospitalized, and then developed typical sort of organ damage, like the heart damage, the lung damage, the kidney damage. And that shows up on tests. And those people actually do quite well going to see cardiologists and respiratory physicians, etc. They got something we understand. But there's this other group of patients, which is the bigger group, I think, who were not that sick with the initial, it might have been like a bad flu, they might have been in bed for a couple of weeks, they weren't in hospital, but then they just didn't recover, and they developed this very debilitating, chronic, relapsing, remitting condition, which can worsen over time if you're not doing the right things. And that is the group where the tests come back normal, and they often have these other overlapping conditions. They might be hypermobile, have bendy joints. They might have a neurodivergent condition. They might have allergies in the background. And so that's a much more complex picture, which is much less well understood amongst the medical profession. And as I say, can be very satisfying to treat. I would agree with Sanjay if you approach it in the right way.
Just to reflecting on what both of you have said there, because it sounds like there can be a lot of symptoms. There can be a lot of other underlying issues that need to be looked at potentially, and worked out whether they are the cause or whether it is long, to rule them out, I suppose, before you get to this assumption that it could be linked to long COVID. So if we're talking about someone who's kind of going in there in an ideal world, is there something that they can or something that they should be doing to ask for? How do they get to that point where they then need to maybe go to a specialist clinic? Or is that something that you have to trust in your doctors to do? But then as South Asians, you maybe want to do that pushing bit, right?
Yeah, it is tricky because a lot of the time, as we discussed at the start, that symptoms are disbelieved or dismissed. And you may get a set of blood tests and they're normal, and then they continue to be disbelieved and dismissed. So the key is finding a doctor who has listened to the story and is willing to do something a little bit different. And so once you've excluded all of the other kind of key things, there are some really important symptoms that you should ask about. And one is something called post-exertional malaise, or PEM, which is a hallmark feature of the people with long COVID who go on to develop a condition that meets the criteria for ME, which is something which has been around for decades. It stands for myalgic encephalomyelitis, bit of a mouthful. Sometimes referred to as chronic fatigue syndrome. I don't like that because I think it dilutes the seriousness of this condition, but quite a large percentage of people with COVID will go on to develop ME, which is the post-viral illness that's been around for decades. And PEM is the cornerstone of that diagnosis. So ordinary activity that, if you're healthy, should be quite easy to do, creates significant fatigue. And when I say fatigue, I don't mean I'm a bit tired. It's bone crushing sort of fatigue where something as simple as having a shower could lead to putting somebody in bed for a couple of days. And that sort of worsening of symptoms after exertion can happen immediately, or it can happen 1 to 2 days later, and it can accumulate. So people can sometimes be okay for a few days or a few weeks, and they'll do activity, and then they'll crash, and you end up in this kind of boom and bust cycle, which is very destabilizing. It impacts massively on people's lives, how they can live, day-to-day function, whether they can work. Very debilitating and quite poorly understood. So that is something that people must be asking about. And then the other sort of key features of disturbed sleep, features of POTS, which I'll hand over to Sanjay about in a moment to talk about POTS. So POTS stands for postural orthostatic tachycardia syndrome. It's one of the things that sits under the umbrella of long COVID. It's often seen in people with ME, and again, it has quite typical features. So I'll maybe hand over to you, Sanjay, as the expert on this subject, to explain what it is.
Okay, so POTS stands for postural orthostatic tachycardia syndrome. This is well, I'll tell you what I think about this. This is a description sold as a diagnosis, right? So the patient says, I stand up, I don't like being stood up, and when I stand up for a long period of time, my heart races and I don't like it. So they go with those symptoms to the doctor, and the doctor says, hey ho, you've got a condition where you stand up still, your heart rate goes fast, and you don't like it, syndrome. And unfortunately, this is the story of these patients because they say, I'm tired all the time. Hey, you've got chronic fatigue syndrome, tired all the time condition. And my gut is all over the place. Hey, you've got irritable gut syndrome, right? But the truth is, although the term POTS is not a very good term because it's a description sold as a diagnosis, we use it because for the lack of a better word. But in essence, what POTS is that it is a condition of autonomic dysfunction. So the autonomic system is broadly divided into our flight and fight responses and our rest and digest responses. So when we are sitting here talking, we are nicely balanced between the two. If a bomb goes off, suddenly our flight and fight system gets activated, our heart rate goes up, our blood pressure goes all over the place. We may get boiling hot or freezing cold. We may feel like our mind goes cloudy, our legs tremble, right? And at that point, we can't possibly say, oh, I fancy a nice snooze, so we are really wired. And at the same time, we're really tired. So this is what happens when we have too much adrenaline. But the pivot of this seesaw, this autonomic seesaw, is in the center. In a dysautonomia or POTS, this pivot has moved to the side. So now what you have is an over-exaggerated sympathetic system response, meaning small things that should cause minimal adrenaline rises cause huge adrenaline rises. Simple things like standing up. Standing up is a movement of arousal. You increase your adrenaline levels because you have to work against gravity. You have to push the blood up. So in those people, what happens is any small trigger that produces a little bit of adrenaline produces so much adrenaline that they almost feel like they've been in a car crash. And so they're incredibly wired 1 minute and they're incredibly tired thereafter for days and days. The issue with the posture side of things comes from the fact that many of these patients have something called joint hypermobility. So many of these patients have an underlying genetic vulnerability, which somehow seems to get unmasked by a viral illness. In the old days, it was glandular fever. Now we have COVID. But basically, this virus comes along and suddenly this genetic vulnerability gets unmasked. And what happens is these people have lax joints, and they often describe that when you ask them about their childhood. Often they're good athletes, and when they're growing up in puberty, they'll notice that they're more fatigued. But they cope. They think we're okay. Then they get the virus and all hell breaks loose and they feel absolutely awful. But in essence, they have lax joints. And the same tissue makes up your blood vessels, makes up your bladder, makes your gut up, etc. So they have laxity everywhere. And when we stand up, gravity would ordinarily pull up blood to our feet. And in normal people, our blood vessels in our legs will squeeze to push this blood up, and we produce a little bit of adrenaline to make the heart rate go up. And that's how we all maintain an upright posture. Our leg vessels have squeezed, and we've produced a bit of adrenaline to make the heart rate go up to keep the blood going up to our brain. In patients with this, that doesn't happen. The blood starts sinking down, the blood vessels accommodate this blood rather than squeezing. And then we have to produce adrenaline, lots of adrenaline, and the heart rate goes up. And that's why these people don't like being stood up for a prolonged period of time. In fact, if you talk to them, they'll generally say, if I move around, if I fidget, I feel better because they're inadvertently using their leg muscles to keep pushing the blood up. But if they're
Mm.
standing still, they feel absolutely awful and they have to lie down. Ironically, when they fidget, they then get told they have ADHD as well. But so unfortunately, they accrue lots and lots of different labels, all given to them by a doctor who's unwilling to look beyond, okay, you've got a gut, I can't explain it, you've got irritable bowel syndrome. Oh, you feel anxious all the time, I can't explain it, you've got generalized anxiety disorder. You've got headaches, I can't explain it, oh, you've got vestibular migraine. So they accrue a bunch of different labels, and POTS is one of those things, right? So POTS is the cardiology diagnosis. You stand up, your heart rate goes up, you don't like it, but they'll also have chronic fatigue syndrome, irritable bowel syndrome, etc.
Do those labels then become a barrier when they're thinking about treatments, and does that does it hinder it?
All these labels serve one thing. They do not improve understanding, they do not improve management, and they do not improve outcomes. What they do is they hinder the patient because they introduce a bias in the next doctor's head. When the doctor opens this and says, oh, this is one of those people, they're probably
Mm.
mad because all these labels are in essence, you know, a polite way, a euphemism for saying they're a bit crazy, they're mad, they're anxious. And so the more labels you accrue, the less time the next doctor gives you.
And
So
actually, when I see that bunch of diagnoses, you can start to weave a picture together, a pattern. Oh, someone's diagnosed them with IBS, someone's diagnosed them with interstitial cystitis. Oh, they've got a bit of anxiety. Oh, and then you kind of put it all together and go, actually, I think this is there's a connective tissue issue here. There's possibly an allergic issue, depending on what sort of symptoms they're having. And they've probably got what we call dysautonomia, which is when that balance that Sanjay is talking about has gone wrong and it's skewed towards one part of the autonomic nervous system that's going ski with. So you can actually sometimes, for me, it's helpful in one way because you're like, oh, it's one of these patients who've got all lots of interconnecting, overlapping, poorly understood conditions, and we can put it all together. But unfortunately, it does lead to a lot of dismissal if you see that list of diagnoses and you don't understand it as a doctor, because we don't get taught. You don't. Sanjay, I don't know about you, I wasn't taught about all of this with medical school, and it's creeping in a little bit now, but not enough.
It's creeping up, it's creeping in and in a big way. And the problem is that you see, if you go to a doctor and you say you're dizzy and you feel awful, and they give you a label and they say, oh, you're a functional neurological disorder patient, you can be seen in the FND clinic. The poor patient then stops at that because they say, oh, well, I've been given a diagnosis, right? Nothing can be done about that. And so there are a ton of these people sitting in an irritable bowel syndrome clinic and an FND clinic and an ADHD clinic, etc., who could potentially get better, but they're never seen in a bigger way. No one sees the bigger picture. So they're content because they've been told, oh, look, you're just very unlucky. Nothing can be done. Just go and pace, just calm your anxiety down. But actually, those people can be healed. They may not be cured, but they can be healed. And that healing comes from, being listened to, be feeling validated, being educated, being empowered to try lifestyle measures, and there are medications that can make a huge difference as well. So I think we're just seeing the tip, but this problem has been there for years and years, and there are a lot of patients sitting in different clinics who are probably suffering from this condition, which would unify all their symptoms, which will give them a unifying diagnosis, and they'll never be recognized.
Mind is racing because I feel this resonating with so many personal experiences, of family members or friends in my life. And I know we said we were going to get onto questions in the end, but I think this is actually a fine point to bring this particular question in. Are there any specific symptoms that are more noticeable in South Asian population, post COVID? Is there anything that's come up that's more specific to the South Asian communities?
So I would say, in answer to that, I'm not aware of any sort of official research on that particular topic, but anecdotally, what I saw in the NHS versus what I see in my independent sector clinics, a lot of this work, if you are going to treat the patients, you have to do it outside of the NHS because the NHS pathways don't exist. But in the NHS, I saw maybe more people who had diabetes or high blood pressure or heart disease to start with, which are conditions that can be more prevalent in South Asian populations, um, and what I would say is people who are slightly metabolically unhealthy to start with, and then didn't do so well with COVID-19 because that is a virus that can affect the blood vessels. So if you've already got heart disease and kidney disease, and then you get a virus that inflames the blood vessels, that can make that worse. So I did see more of that. I say in the independent sector, I don't see very many South Asians at all. So there's an inequality there in who's accessing care in one set. And also, I think it's important to realize that um, a lot of the differences we see that we put down to race um, are really down to socioeconomic issues. The only difference really genetically, I mean, humans are all 99.9% genetically the same anyway, and we've got a bit more melanin in our skin, and someone who's black has got a bit more melanin than us in their skin. But genetically, actually, we otherwise function the same. So if people who are black or brown have worse health outcomes, actually, that's often due to the socioeconomic conditions that they're in and the types of jobs and their exposure to viruses, etc. So it's really important to make that point. What I would say, it's sometimes harder to diagnose things in someone with brown skin. So, for example, one of the classical symptoms of POTS is blood pooling. So they stand up for 10 minutes against a wall, you do the blood pressure and heart rate, and you look, and you'll see lovely pictures online of these lovely purple legs, the acrocyanosis, as it's called. But in brown skin, it doesn't show up in the same way. As you say to an Asian person, oh, do you get blood pooling? They say, oh, what's that? But they're undergoing the same process. So I think we have to think differently about how we diagnose these conditions in the South Asian population. And, also goes for the Black population. Rather than it being specific to South Asians, if that makes sense.
Yeah, no, it doesn't. But actually, I think it was really important for you to clarify that because I think there is a lot of assumptions around we are a bit different or, we have different issues compared to, to people not from South Asian communities. So I think it's a really key distinction to say that actually, essentially, there's very little that should affect us and not affect others. It's just there is more of the socioeconomic situation that we need to be looking at. I think that's a really important point to note. We've talked a lot about symptoms and the various ways that this can be presented. When we think about treatments, whether it's through the healing that you talked about, Sanjay, or whether it's through actual, treating the condition, what are the cornerstones that we have available?
I think the most important is for people to feel that they're being heard and being seen. That I think beats everything else. The number of people who come to me and say, in fact, one of the saddest things I hear isn't I'm tired, it's maybe I'm imagining it. That to me is by the time some people reach clinic, they've spent years apologizing for symptoms that they never chose. And I think illness is hard enough. Having to prove you're ill is another illness entirely, right? So sometimes the first part of treatment is simply saying, I believe you. That doesn't mean we immediately know the diagnosis, but it means that we recognize suffering and we are putting ourselves out there and saying, we will help you to the best of our abilities. And where we can't, we will be humble enough to ask someone else. And that I think is important. Now, there are a bunch of things we can do as doctors. One, there are lifestyle measures that can make a difference. Encouraging people to hydrate better, encouraging people to eat healthier, encouraging people to practice things like sleep hygiene, wearing compression garments, increasing their salt, fluid, electrolyte intake. All those things can help. So that is important because in this setting, when there's all this blood pooling in the legs, you want more blood in your system. If you can fill the body up with more blood, and if you can encourage that blood to go up by wearing compression garments, that can make a difference. The second thing is physiotherapy, dietetics, etc. And you need specialized physiotherapies. You don't want to go to a physiotherapist who doesn't believe in the condition. You want to go to someone who recognizes that these are different people. They can't cope with the same exercises that other people can. In fact, much of their exercises have to be in a recumbent position rather than being upright because they feel so awful. And you don't want them to expend all that energy doing physiotherapy because then they're struggling with their PEM for a week afterwards. The third thing and the most important thing is medications. And a trial of medications is always worthwhile and can be very helpful and can really make a difference. And the fourth thing, I think, is advocacy. When you have a doctor who is willing to work with you, they will be your advocates and they will try and use their position to make life easier for you. So things like working with schools for children who are struggling with these symptoms, working with employers, helping them get PIP, helping them get blue badges, all those things, that is part of the healing process. Curing is okay, I've identified a disease, I'm going to give you this and you'll be cured. Curing may not necessarily be possible, but healing is. And it takes time and it takes patience and it takes humility and it takes empathy.
Yeah, I mean, I agree with everything Sanjay said. I sort of think of treatment in three kind of pillars, if you like. Much of what overlaps with what Sanjay said. But firstly, I kind of treat anything treatable. So when I was working in sort of severe asthma services in the NHS, we used to talk about treatable traits. So if they've got allergic disease, you can treat that. If they've got sleep apnea, a lot of people who are hypermobile develop floppy airways and develop sleep apnea, so you can treat that. If they've got dysautonomia and their heart races every time they stand up and they're on that spectrum of POTS, even if they don't hit the diagnosis of POTS, you could treat that racing heart rate and bring it down. So there's all these, some of people are iron deficient, B12 deficient, because their guts get affected and then they can't absorb these things. So we treat anything that's treatable. The second pillar is really about pacing. Okay, so pacing is a term that I was not familiar with before the pandemic, which is quite shameful actually now thinking about it. But in an energy limiting illness where you have a set energy envelope, and it's a little bit like having a faulty battery. So the people who have PEM and meet that criteria of ME, they're akin to having a faulty battery. So whereas you might wake up with 100% battery, someone with ME or long COVID, if they fit that bill, might wake up on 20 or 30%. And then everything they do drains that battery a little bit. Thinking, speaking, walking, eating, drinking. At the very severe end of the spectrum, people might be bedbound and all of their energy is going onto digesting their food and one toilet trip a day at the very severe end. And I have a number of patients who are completely bedbound, tube fed, because their guts no longer work, living in darkened rooms. So it can be extremely severe, this condition. But at the other end of the spectrum, they might be on 80% and still have to, some people can work, but just not go to the gym on top of work. So that energy has to be managed very, very carefully. There's a lot of science behind that, which we've taken from exercise physiology and how athletes train and aerobic thresholds and lactates and all this stuff I can't really go into, but there is a lot of science behind pacing properly and keeping under that energy envelope, which means that you can stabilize that baseline. And then once that baseline is stable for a period of time and we're not going into energy debt all the time and booming and busting, you can start to build recovery into that. But that can take a number of months. It can require medication, support from a physio, etc., those lifestyle measurements that Sanjay was talking about. And the third pillar is what I call the landscape for health. And this is something I've thought really hard about over the last 5 or 6 years, because just because you don't have a defined illness or disease doesn't mean it's normal. Okay, so you could have a ferritin of 30 and be told that's normal because it's not causing anemia, but that might be enough that it's causing you symptoms because it's dropped down. So your breathing pattern, you may not have a lung problem, but your breathing pattern may not be normal. And all of these things, how is someone breathing? How are they sleeping? What are they having nutritionally? How much stress is in their life? How much is fight or flight being triggered by their environment? All of those things kind of need looking at. So it's a very, very holistic kind of way to look at healing and recovery. And that's why you need that multidisciplinary team around you with a dietitian and a physio and symptom support in other ways. So that's kind of how I look at it. And I'll work with people for on average 18 months to 2 years to try and get them through that, because recovery in this illness is not quick. It can be 5% a month. So you see someone after 6 months and they're like, I'm, maybe 10, 20% better. And you're like, okay, that's a good sustainable rate of improvement. And it takes time and it takes effort from everybody to support through these illnesses. So that's kind of my approach to treatment. Yeah.
I think with time and effort, it's bearable when you have holistic support, because you are being, that all important thing that you've both been saying is that you're being listened to, you're being acknowledged, you're not making it up in your head or you're not imagining it. Like, that's the key here. Now I'm conscious of time and I do want to get to some audience questions, but I did want to ask you this important, because I think this is quite an important point. When COVID was prevalent and a big talking point, it generated quite a bit of misinformation, particularly online. What are some of the biggest misconceptions, myths that you still, that both of you still hear today, that people kind of keep bringing up?
I think one of them is that this is somehow some sort of psychosomatic illness, which means it's kind of generated from the mind, and it's really difficult, because when you lump a lot of different things together under one umbrella and call it the same thing, and you don't have a diagnostic test, actually, there are some people who will improve with some relatively simple things and actually reducing their stress and doing some mind body work. Absolutely, you can get better. And I'm a big fan of all of that stuff. I think anything you can do to reduce that sympathetic drive in your body, so that holistic, the mindfulness meditation, all of that kind of stuff, I'm a real big advocate and fan of. But I don't think it's the only thing that should be offered to patients. And there is definitely a school of thought that that's all you need to do. But we don't treat any other complex chronic illness like that. In when I worked in a very specialist service in respiratory, we had 2 psychologists on the team, but we also had 6 consultants and 5 physios and dietitians. And so you do it holistically, and you don't say, well, that's all you need. It would be like saying to diabetics, you just need to see a dietitian, but we won't put a doctor in the service to give you insulin. So that's one of the really big myths that's still out there, that people don't need drugs and they don't need treatment for symptom support, and they just need to do some brain retraining type programs, which have their place. I'm not saying there's anything wrong with those, but I do still think that narrative is out there. Would you agree, Sanjay?
Absolutely, I completely. And you're quite right. I mean, we have become a very protocol-centered profession. If it's not in the protocol, it's not worth bothering with. And this teaches us that we have to be patient-centered. And that I think is fundamentally important. I think it's you know, and the other thing I would say is that wherever you go, oh, well, there's no evidence, there's no evidence, there's no evidence. How are you going to build evidence if you don't have any experience? But if you're not going to build any experience on the grounds that there's no evidence, then what happens? And this is the crazy world we're in now, where no one is willing to do anything unless unless they've been given a list of instructions by a body like NICE or something, and that's all they do. So, so if there is a thing that we don't understand, in the old days, what used to happen was a person would go, the doctor would listen to them, they would say, okay, this is what it sounds like. Let's try this. And let's make our observations. Let's see what good it does. Let's do that. And then that's how we develop our experience. And then eventually once we've built that, we can produce some evidence, etc. Now, no one is prepared to do that. The patient is fobbed off by saying, well, there's no evidence. It's not in the protocol. The medications are not licensed for this indication. Just because it isn't, the doctor says it's not my problem, but this is still a problem. This is a societal problem. This is a workplace problem. This is everyone's problem. And so for me, I think that what it has taught me here is that this is what we need to listen to the patient. The questions, the answers, everything begins and ends with that patient in front of you. And therefore, it is wrong to try and go back to outdated textbooks and use our information that we glean from that and say, oh, well, it's not in that textbook, so you're mad, go away.
That's really interesting. That there is that kind of mentality that still exists, and it exists in many in many industries as well. I just want to start
I would just
touching.
add one thing to that, sorry, that
Sure.
Sanjay has said, and that is that within the NHS, because there are such strict frameworks, because we've become so protocol driven, actually, there are doctors who do want to help and want to prescribe, and they're not allowed to, and actually could get into trouble if they did start prescribing some of these things. So, actually, we've disempowered doctors from doing the let's try this repurposed drug thing as well. So, as you know, and I think both of us worked in specialist services where you could try things off label and that was perfectly acceptable. But that is not how GPs are empowered to practice now.
One other thing I want to add is that just because a condition is not dangerous does not mean it's not important. So long COVID, POTS, these are not conditions that shorten a patient's lifespan, but they impact on quality of life. And the current kind of stance is, well, it's not dangerous, go away. Quality of life matters. Quality of life matters more than anything else. We spend our whole lives giving people statins. We don't improve their quality of lives, and we'll never know whether we've improved their length of life. Yet here are patients who are saying, look, I'm suffering. Can you help me? Oh, there's nothing we can do. Go away. Whereas actually, simple things can make such a big difference to their quality of lives. It can be the difference between a mother saying, I haven't walked for 2 years, to writing a card and say, hey, I hosted my child's birthday today for the first time. Thank you.
No, definitely. And I think, with these conversations and having people like you and Binita explain and give people, I think, give patients as well a bit of empowerment to kind of go and say, I need to push a bit harder. And just on that note, one of the questions that's come in is around looking at representation disproportionately in South Asian women in particular, are they, we're already talking about the challenges within South Asian communities in general, but if we look at women, are they further misrepresented versus the men in our communities?
Yeah, there's definitely a hierarchy in terms of uh, being underrepresented and minoritized, and women's health we know is massively neglected. Um, but even within that, if you're a brown or a black woman, you are even more disadvantaged. So there's some research around endometriosis, for example, that if you're a South Asian woman, you will, even if you seek help earlier, you will wait much longer for a formal diagnosis. We've seen it in maternity statistics as well. Black women are 4 times more likely to die than a white woman. So there are these there is structural racism sort of built into our health system, into our medical training, into our institutions, and that's just a fact. That's not, I haven't made that up. There's lots and lots of research and evidence. I did want to show everybody this book. It's a brilliant read. It's called Unheard: the, the medical practice of silencing, and it's by a friend and colleague, Dr. Regeshri Daryawan. And if anyone's interested in understanding why we're in a place where if you're a woman or you're brown or you're black, you are disadvantaged, and how that has evolved over time, it's a brilliant, brilliant book. Very, very enlightening. And there's also a book by Angela Saini called Superior, and it's the science of race. And she talks all about how what I've been talking about how that structural racism has kind of become embedded in our day to day. So there is a lot of evidence and research around that, and women's health in particular, which is really interesting and definitely a subject for another whole webinar.
But it's not just structural, um, situations which might impact misrepresentation when we look at South Asian women. Am I right? I'm making an assumption here, but I would also assume that there's also, within our communities themselves, we already have issues that we're battling with in terms of misrepresentation or women not being taken as seriously, perhaps, or this kind of pushing through, you know, uh, kind of mindset that we already have as South Asian women. Do you see that as a barrier as well, or do you think that's less of a problem? You've both gone
Sanjay?
silent.
No, no, no. No. I think, of course, I think it is a problem. Absolutely. There's a lot of stigma. There's a lot of shame. There are still very traditional structures in some communities and cultures. Things are changing, but all of those issues, we shouldn't skirt around them. There's definitely cultural issues as well as structural and societal and political. So that I think women are finding more of a voice in South Asian communities. I think that's why South Asian Heritage Month has it's really created a platform to have those conversations. Um, and we have talked a lot about those sort of more thorny issues in various events over the years. So that is definitely a thing. I don't want to pretend I represent all women of South Asian backgrounds and understand all cultures and communities. There's a lot I don't understand as well. But these are conversations we don't even have in medicine. I think
Mm.
that's the key point, that we don't talk about it, we don't teach it, we don't think about it. So everything is designed around what is normal, um, which is, that excludes a lot of the people that we're talking about.
We've had a really nice comment on the chat as well to say, as someone with FND, fibromyalgia, and ME, I wasn't listened to, and it takes a mental toll on whether or not it's worth it because it's not taken seriously. So just highlighting a lot of the points that both of you have made around that healing. Thank you for sharing that. And another question that's come up is about treatments and long COVID clinics. If how do people request support? Can they go through their GP? Do they need to find it by themselves?
So the kind of NHS structures are changing. I think what happened was in 2020 and 2021, Britain was absolutely ahead of the game. We set up an infrastructure of long COVID clinics that was world leading and at a time when other countries were not thinking about it. And those were set up on the best information we had at the time. What's happened since is we've now got 500,000 research papers on COVID-19 and what it does, but none of that is translated into any treatments or very few treatment trials, certainly in the UK. There's a lot more going on in Germany and the US. And we're not testing for COVID anymore. So actually now getting a diagnosis of long COVID is very difficult because no one's testing. So you have a viral infection, you don't feel very well afterwards. Well, how do you know it was COVID? No one's testing. So the numbers of people being referred into the services was dwindling. And so a lot of the services have been axed. So we've lost about 50% of the long COVID services from across the country. And what we are now looking at, so I'm involved in some work with the government around looking at ME services and actually creating more holistic services that can encompass long COVID, ME, and these sort of overlapping illnesses. And there are a couple of really standout services across the UK that are doing this really well. They're still not don't have doctors embedded in them a lot of the time, which I think is a problem. But at least it supports someone who'll listen, who understands. So it is a complete postcode lottery at the moment. It's a very unsatisfactory situation. That is acknowledged at high level, and I think there is work going on to address it, but it's going to take a long time to stand up new services. And it'll really be at the discretion of the local, what we call integrated care boards, of whether these services get commissioned and stood up. So the louder the community can speak and the more noise and the more patient advocacy, the better. Write to your MPs, create a case for it, because it will otherwise just will keep losing more and more services.
And do you think that's key, Sanjay, is that people going in still asking for it and pushing for that, and that'll help support what Benita's saying in terms of garnering that sort of additional, support higher up to make sure we have the services enabled.
Yeah, I agree. I mean, I think medicine at its best when it is at its best when it combines sort of science with humanity. Science can help us explain disease, but humanity helps us recognize suffering before science has all the answers. So if anyone's listening, I think the one thing I would recommend that you remember is that you should never have to earn the right to be believed. If something doesn't feel right, don't ignore it. Keep asking questions, keep seeking help. Medicine may not have every answer yet, but your symptoms, your experience matter. And therefore, again, please don't go to the doctor and just take it that the doctor says, well, there's nothing wrong. I don't believe in it. This happens all the time. In fact, the training of doctors has been reduced to the point where, many doctors are very limited in what they see. And when they're faced with this, sometimes rather than acknowledge the fact that there's a knowledge gap, it's easier just to say, oh, well, you've got this, or go away, or go away. I think it's really, really important. If you're struggling, it could well be something like autonomic dysfunction. And there are treatments that can make a substantial difference to a person's quality of life, to the point that I have a 39-year-old doctor who first came to see me about 10 years ago. She'd sign a do not resuscitate form. She had said, do not resuscitate if I have a cardiac arrest. Why? Nothing, no terminal illness in her diagnosis, nothing like this. It was all these symptoms that completely destroyed her. Today, she's the mother of a child. She's working again. So recovery can look like this. It can make a huge difference. So, but I think the most important thing is people keep asking, and you don't have to fit into our box. That is really important. If you don't fit into our box, that doesn't mean that's your problem. That's our problem. We need to have wider boxes. We need to be more humble, and we need to realize that nothing is neatly packaged like it is in the textbooks.
So really don't be afraid to keep asking as well, because I think, sometimes people can feel like they're an inconvenience, right? Especially if they are going back and saying, I'm still not well, I'm still not well. But, you're recommending what you're saying essentially, like if you are still not feeling well in yourself, just go back and ask the questions.
Yeah, I
Asma,
think, I
can
mean,
I? Oh,
sorry,
sorry.
go on. Sorry,
I'm
Binita.
just conscious of time, and I really did want to
Yeah.
pick up on one of the questions that's in the
Of
chat
course.
from Paul Thomas. Thank you, Paul. So, as Paul's asked a question about do South Asian people data-wise statistically have more diabetes? Absolutely, yes. So the statistics show that you're 2 to 4 times more likely to have diabetes, type 2 diabetes, if you're from a South Asian background. And melanin isn't a hormone, it's a pigment. So it's just a pigment. It's not metabolically active like you might be thinking of melatonin, which is more of a hormone. And also comment later down just about the structural racism. I think there's a lot of misunderstanding about what that means. And I don't mean that you misunderstand, Paul, but I'm just saying generally there's a misunderstanding. And where I try and make an analogy is as a doctor, I've been through my whole life dealing with people who've got disabilities, right? And I would have liked to have thought I was very open and, knew a lot about disability. And then when my daughter was very poorly, I had about an 18-month period where we had to use a wheelchair for her to be moved around outside the house. And being in the shoes of somebody with a disability for the first time, through my daughter, I just realized what an ableist world we live in, because society is structured for people who don't have disabilities. But I couldn't see that. I wasn't anti-disability. I certainly was, I knew all about it. If someone said, you're not very supportive of disabled people, I'd have been absolutely horrified. But I didn't have a clue, not a clue. And it's the same with racism. I think until you've lived it, you've experienced it, you've come up against the barriers and the structures, you don't understand, you don't see them. And so I think it's very hard for someone to really understand how it is ingrained in things like medical training and in our hospital structures and in our outpatient clinics. Because we're not we and you have to really try and understand it, and that's where representation becomes super important. Because if you don't design a space for somebody with a disability, if you don't design that by talking to people who have disability, you're going to get it wrong. And that's why those voices really need to be in the room. And final point I'll make on this is when you look at something like diabetes, are we genetically different? Why are South Asians getting more diabetes, something to do with other genes, right? Well, maybe, possibly, or at some level, but far more important is our migration stories. How did we come to the UK? And when we came to the UK, what sort of jobs were our grandparents doing? And where did they settle? Did they settle in an inner city? Are they exposed to how they got more poverty? Are they exposed to more air pollution? And are there children living in multi-generational houses and with crowding, etc.? And it's those social determinants of health that actually lead to those discrepancies in health outcomes far more than genetics. It's very easy to go, it's just genes, but there's no evidence for that actually when you start reading about this. Anyway, for another topic, but I did just want to pull out those points.
Thank you. Really important. And I'm conscious that we're at time. Any final quick thoughts, Sanjay, you wanted to share before we wrap up?
No, no, I think it's just worth saying that the average number of years that a patient struggles for a diagnosis or to be believed is 7 years. So the people who come to me from symptoms to the point that someone says, I think this is real, is 7 years. And so it's really, really important that anyone listening, anyone who knows anyone who's struggling, understands that this can be a long, long journey, and you have to try and seek out the right people and be very vocal about your symptoms and not give up and not lose hope, because there may well be a path to recovery.
Thank you. Uh, And we are at time, as I said. So thank you so much to everyone who's joined. Thank you to Dr. Binita Kane, Dr. Sanjay Gupta for sharing their expertise, their time, and just on that note of, if you are looking for help, we will share a list of resources from organisations that have supported today's event and where to find some advice and further support as well. And we do have some health videos as well on our YouTube channel. If you want to look on the South Asian Heritage Month channel there are some great videos to catch up with. And do check out the website, see other events that are coming up, past events that have happened if they are ones that you can watch back. It is such an important month for us all to be part of and be paying attention to. And thank you to everyone that joined and the great questions as well. Have a lovely rest of your evening.